This part of the course is going to address conditions that affect the joints, and of course that is arthritic conditions. It's a little different maybe from other lectures in this course where we focus specifically on the medications and then talk about what they're used to treat. Here we're going to talk about the conditions and then focus on what the medications are used to treat these conditions that are affecting the joints. But since joint disease is such an important part of our practices, these medications also become very important and of course very common. So we have to start by identifying the fact that arthritis is really two different conditions, or there are two primary types of arthritis, which are of course osteoarthritis, we'll talk a little bit about the pathophysiology there, as opposed to rheumatoid arthritis. And granted that both conditions are associated with joint disease, joint destruction, and dysfunction, but they really are quite different from each other in terms of their pathophysiology. So as we look at osteoarthritis, the characteristics, it is the most common joint disease. If we look at all the things that can happen to our patients' joints, including other types of arthritis, osteoarthritis is by far the most prevalent. And it's typically attributed to a progressive wear and tear of the large joints, like the hips and knees. It probably is more complex than simple wear and tear. We understand now that it often has to do with repair of the joint not being able to keep up with micro trauma to the joint surfaces, the chondral surfaces, the cartilage itself, and ultimately resulting in changes in the subchondral bone. But still, it typically occurs in older patients, older joints, or in joints that do have some biomechanical or structural dysfunction that leads to abnormal stresses on the joint, and again, eventually the microtrauma that becomes progressive because the repair of the joint is not adequate to fix these joints on a day-to-day basis. So let's turn our attention to the primary drugs used to treat osteoarthritis. We'll talk first about analgesics. These are of course pain medications which are critical in allowing the patient to remain active with an osteoarthritic joint. We'll then turn our attention to possible ways to protect the joint, maybe even restore joint function or restore some of the function of the joint cartilage and prevent some of the breakdown of subchondral bone. So the first thing we're going to talk about is how to treat pain, or use of analgesics to treat a patient with osteoarthritis. Acetaminophen is often the first choice. This medication was discussed in much more detail in a different lecture in this course, The Treatment of Pain and Inflammation, Part 2. But as everyone usually is aware, acetaminophen is often advocated as an over-the-counter pain medication because it is easier on the stomach. It tends to produce less gastritis than some of the other medications we're going to see, analgesic medications. And in earlier stages of osteoarthritis, inflammation is not a key issue. Granted that inflammatory changes in the joint do occur when osteoarthritis becomes more progressed because of changes in the synovium and an actual synovitis. But early to moderate stages, inflammation is not the key issue. It's really related to pain, which makes, again, treatment with just a pain medication like acetaminophen often very valuable. The other major option are the NSAIDs. Again, these were addressed in Part 2 of the Treatment of Pain and Inflammation in this course. They can be used early in the course of osteoarthritis or any other stage, well into the advanced stages, especially in the later stages when there is some degree of inflammation. NSAIDs are different from acetaminophen, of course, because they do produce good analgesic effects. At the same time, they produce anti-inflammatory effects, and the name tells you that, non-steroidal anti-inflammatory drugs. So these are a mainstay for most people with osteoarthritis. And a variation on the NSAID is the COX-2 inhibitors, again addressed in Part 2 of the pain inflammation lecture. They're slightly different from traditional NSAIDs in that in some patients they can reduce the pain with less toxicity to other tissues like the stomach, so we see less gastritis, and possibly less other effects. There is even some information they may actually help rebuild some of the cartilage, although that's still in its infancy. So it's a somewhat newer option for people with osteoarthritis, and some of our patients and clients do really well on this drug. The most common and the only COX-2 inhibitor on the market right now is Celebrex. But as I said, some patients do really well on this drug. Other patients, it doesn't work as well as maybe a more traditional NSAID, and in some patients it actually has adverse effects that prohibit its use. So it is an option. It is certainly not going to solve all the problems for all our patients with osteoarthritis, but it certainly is a nice addition for some patients to treat their pain.
Press pause and read this slide before proceeding to the next one for the answer.
We then look at some strategies that might be helpful in actually protecting the joint, or even restoring some of the function or some of the health of the joint tissues. Analgesics don't typically do that, especially the traditional NSAIDs and acetaminophen. But now we do have some ideas that we might actually help rebuild these joints to some extent, or at least protect them from further damage. The first strategy is called viscosupplementation. We're trying to supplement the viscosity of the synovial fluid. And this is done by injecting hyaluronan directly into the joint. I often liken it to having the oil changed in your car. It builds up the viscosity, restores some of the lubricating properties of the synovium. And by doing so, maybe helps nourish the joint and provide a little more protection of that joint. It's an option for people oftentimes when they're going to eventually need a joint replacement, but maybe it's a younger individual where they're trying to prolong that surgery as long as possible, or delay it as long as possible. And viscosupplementation may help do that. It doesn't work tremendously well in some patients, but it is that option to at least try it. A series of injections, build up the synovium, and help protect or delay the need for a replacement. The other option is to use substances called glucosamine and chondroitin sulfate. And these are not considered drugs by the FDA. They're considered nutraceuticals, which are nutritional supplements that have pharmaceutical properties. And as such, they're available over the counter. So not needing a prescription, patients can go buy these substances and try them. The idea is that they're going to provide the body with the building blocks that the joint needs to build new cartilage and sustain the synovial fluid. It's worth a try in some patients. And again, a lot of physicians will say, well, you can try it. If you're going to try it, you should stick to the prescription dose, not exceed it, but make sure you take the correct dose that's listed on the package. And if it works, it often takes a couple of weeks for you to realize the benefits. So maybe not take it and after a few days say, well, it's not working for me. If these benefits are going to occur, it's usually going to occur after several weeks sometimes of regular dosing, daily dosing. If there are side effects, nausea, vomiting, those kinds of things, then clearly it's not worth the risk. But for some patients, it's at least an option. And again, we're going to run into patients that really swear by this intervention. Other patients have tried it and it just didn't work. So it is an option. If your patients are considering it, certainly refer them back to the physician to talk about it in more detail, because even though it is over the counter, it is beyond our Practice Act to recommend our patients to take this substance, because it's beyond our physical therapy interventions. We're now going to talk about a very different condition called rheumatoid arthritis. Characteristics here are pain, stiffness, inflammation, damage in various joints. They can be some of the larger joints in the body, like the knees and the hips, but often involve some of the smaller joints, the wrists, the metacarpophalangeal joints, and the interphalangeal joints of the hands, and the feet. Fairly common, affects about 1% of the population, much more common in women than in men. And we believe that it's different from osteoarthritis, especially in its cause. It's very clear now that rheumatoid arthritis has an autoimmune basis, where the immune system has malfunctioned, and the immune system has begun attacking these joint tissues and joint structures. And that's very important because knowing that has led to some nice interventions that we'll talk about now that may help control this autoimmune destruction. So in terms of the autoimmunity in rheumatoid arthritis, we believe the immune system is triggered by some other maybe infectious agent, a virus or even a bacteria, or maybe even an environmental trigger. And this is not happening in everyone. There's obviously some genetic basis to this, but we see this so often in autoimmune diseases where there's a genetic predisposition that's triggered by some environmental or other infectious factor. And we believe that's true here. In any event, the immune system malfunctions and generates this attack on the cellular tissues. The destruction can be pretty remarkable in terms of its intensity. So controlling this autoimmune response becomes very critical in helping maybe even control or modify the progression of rheumatoid joint disease. So it's time to turn our attention to the actual drugs that are commonly used in rheumatoid arthritis. And before we get to the immune system modifiers, we have to talk about treatment of pain and maybe more mild to moderate inflammation. And in that situation, the NSAIDs are clearly the cornerstone of treatment. They can be used at any stage within the disease. They offer the dual benefit of providing pain, some pain relief, analgesia. At the same time, they're providing some anti-inflammatory effects. So clearly, they're a mainstay in the treatment of many, many people with rheumatoid arthritis. We also have to really talk a little bit about the glucocorticoids. And again, these drugs, as well as the NSAIDs, were described in much more detail in Part 2 of the section of the course that deals with pain and inflammation. And we know glucocorticoids are our best anti-inflammatory interventions, period. They're very good at treating inflammation. The problem is they come with a pretty profound number of potential side effects, which can be very serious. And more important, some of the side effects of the glucocorticoids involve weakening of bone and joint tissues. So here we've got an intervention that's trying to control the inflammation at the joint, but can also lead to some breakdown of the joint tissues, the bone, cartilage, ligaments, and periarticular tissues, including muscle and tendon. So obviously they must be used sparingly. But in an acute exacerbation of rheumatoid arthritis, these drugs can be extremely helpful. So in general, we see patients try to use these as sparingly, maybe just during the exacerbations, or if they need to be on an anti-inflammatory steroid, glucocorticoid, for prolonged periods, to use obviously the lowest possible dose to maintain that. And again, for more information, please refer to the other lecture, Part 2 of the pain inflammation. We want to turn our attention now, though, to these very important drugs called DMARDs. DMARD stands for disease-modifying anti-rheumatic drugs, because what we're trying to do here is modify the immune process that's causing the joint destruction in the first place. So what are we trying to achieve in terms of clinical effects with these DMARDs? Obviously, what they're trying to do is not just treat the pain, but actually delay or possibly, ideally, even reverse the progression of the joint changes that cause rheumatoid arthritis. And these are, again, they're important drugs, but they do come with many side effects. We'll focus on some of these. If they are tolerated well, the idea being start them as early as possible, because it makes much more sense to do that than wait until there's already been a lot of joint destruction. If they actually are going to do what the name says, delay the progression, well, then clearly it would be better to start these drugs earlier in the course of the disease. And there are a lot of these now. This is a growing list. We've gone from some drugs that were more traditional to some newer drugs. They can be used alone, but oftentimes can be combined with each other in a bit of a cocktail to provide a better overall control of rheumatoid joint disease. So let's Let's introduce first some of the traditional DMARDs. By traditional, we mean these drugs have been around for quite some time, and they were some of our first real breakthrough drugs in trying to control the progression of rheumatoid arthritis. And we'll just list them here, and then we'll talk a little bit about how they work. And what we're going to see is we start with a drug like methotrexate, very common drug. We may see this also used in cancer, and it's actually used for very similar reasons, but at a different dose. In rheumatoid arthritis, we use a smaller dose to help control the proliferation of lymphocytes, but it's used for the same reason at a higher dose to control cancers that have a lymphocytic basis. Second drug, Oranafin, is one of the original gold compounds. It has gold, elemental gold, actually in its organic structure. Hydroxychloroquine is a antimalarial that we found useful for treating rheumatoid arthritis. Cyclosporin, you can see the trade name Sandimmune, gives you the implication right away that it's a drug that moderates the immune response. Same thing with penicillamine. It looks a lot like penicillin, the name does, because it is structurally similar to penicillin. Sulfasalazine and azathioprine, same thing. These are very characteristic immune system depressants or moderators. And likewise, the final drug, leflunomide. So like I said, these drugs are all pretty dissimilar from one another in terms of their chemistry, chemical categories, but they do share that one commonality: try to suppress the immune response. We'll take a look in the next slide at exactly how they try to do this. So how do the traditional DMARDs work? Well, the general strategy is to inhibit the immune response by doing things like inhibiting the production of cytokines. These are things like interleukins, interferons, tumor necrosis factor. These are small proteins that the immune system uses as messengers to activate other immune system cells. These drugs also inhibit the cellular activation of the monocytes, the T lymphocytes, the B lymphocytes that are actually promoting the joint destruction. So what we see is these drugs, they affect many different aspects throughout the immune system. And that's the problem, really. They're relatively non-selective. Because they inhibit many aspects of the immune response, we tend to get a blanketing of the entire immune system. Now that's helpful in rheumatoid arthritis, but clearly it's going to open up the patient to more infections and other problems because their immune system is not quite up to par. Obviously, dosage is very important here. We're always trying to find the dose that is just enough to quiet the immune system down just enough without actually removing its ability to do its job, mainly to fight off infectious agents. But obviously, that's a pretty fine line you have to walk between suppressing it enough to control rheumatoid arthritis and not over-suppressing it and causing a lot of infections and other immune system problems. And in some cases, the exact mechanisms of these drugs are simply not well understood. Drugs like the gold compounds, we know they work, we know their structure, but it's not really clear exactly how they affect immune responses. Some of them it's less, it's more obvious how they are suppressing immune function, but not always. So these have been, as I said, they've been around for a long time. They do come with, they're pretty tricky to use. They do come with this I say price tag of side effects, and we'll get into some of the toxicity a little later, but a lot of patients simply couldn't tolerate one of these traditional drugs because the side effects. Now, because the traditional DMARDs are fairly tricky to use and they aren't well tolerated by some patients, there was a big emphasis to develop these newer or so-called biological DMARDs. What we're trying to do is be a little more selective in how we moderate the immune response, and if possible, inhibit certain aspects of the immune response that are especially problematic in rheumatoid arthritis. Not just quiet the entire immune system, but go after specific components of the immune response that seem to be the most destructive. So we're going to start by talking about drugs that inhibit a very important player in the immune response called tumor necrosis factor. And then we'll talk about a specific drug called anakinra, which inhibits a different component of the immune response.
So here are tumor necrosis factor inhibitors. And as I said a second ago, they're different from the traditional DMARDs in that they do go after a very specific component of the immune response called tumor necrosis factor alpha. And this specific mediator or messenger is very important in rheumatoid joint disease in promoting the destruction associated with rheumatoid arthritis. So that's good. Being relatively selective allows it to have a lower risk of serious side effects, but still still a very important but tricky drug. It does produce some pretty severe side effects in some patients. And we have a growing list of compounds in this category. The first one, one of the first ones was etanercept, and then we've got several others now that you can see end in that MAB ending. They're a generic name, like infliximab. When you see MAB at the end of a generic name, you're talking about a monoclonal antibody, a drug that was produced using cloning techniques that goes after a specific antigen. In this case, it recognizes the tumor necrosis factor as that antigen and inhibits its function. So this has been a huge breakthrough. Rather than suppressing the entire immune response, we want to maybe slow down one of the key messengers that's promoting that joint destruction, and that's exactly what these are doing. Now this diagram shows schematically how tumor necrosis factor inhibitors work. The tumor necrosis factor, or specifically the alpha tumor necrosis factor, is shown by these large yellow, to me they look like large yellow marshmallows. This is the substance that's produced by the immune system, and it's attaching to these pink cylindrical structures on the joint surface, and that's leading to destruction of the joint. What the drug does, the tumor necrosis factor inhibitor does, is it floats around. It's solubilized. It's not attached to the joint tissue, and it floats around and acts as a magnet for the tumor necrosis factor. Tumor necrosis factor then attaching to the non-joint pink cylinders in this picture is not available to then attach to the joint. And so it's an ingenious mechanism, pretty simple mechanism, where by creating the binding protein essentially as a drug, we can allow it to float around in the bloodstream and glom onto these tumor necrosis factor mediators so that they can't then attach to the joint. The next major option we developed to treat these, to be more specific in controlling autoimmune response in rheumatoid arthritis, is a drug called anakinra, or Kineret. It blocks the effects of a different chemical called interleukin-1, which normally binds to joint tissues and promotes destruction of those tissues. You see a diagram here. The large red structure is the interleukin-1 molecule, and it's trying to attach to a receptor on the joint. But the drug is blocking that effect. The drug is a true blocker. It sits on the receptor so that the interleukin-1 cannot attach to the receptor and cannot cause joint tissue destruction or damage. So, like we saw earlier, this is a fairly selective effect. These drugs do not impair other aspects of the immune response. And it's tolerated fairly well, especially compared to some of the other DMARDs, especially some of the more traditional DMARDs. The drawback is it's only moderately effective, but still some patients may really benefit from this drug to help maintain exacerbations and promote better joint health throughout the course of the disease.
Press pause and read this slide before proceeding to the next one for the answer.
I mentioned earlier, these drugs can be used alone, but oftentimes they're not. They're used in combination. By combining 2 or 3 drugs, we may get a better effect using less of each of the drugs. Each drug helps maybe even come at the problem from a slightly different angle. In this sense, methotrexate is often the cornerstone or the center of this cocktail effect, with other traditional or maybe even some of the newer, more selective drugs being added to this cocktail as needed, depending on the patient, the severity of the disease, their age, and many, many other factors. There was a lot of concern originally that since these drugs are fairly toxic, by combining several together, wouldn't that increase the risk of toxicity? It looks like that's not necessarily true. That combinations of 2 or 3 different drugs does not necessarily increase the risk of toxicity over a single drug called monotherapy. So these combinations have been very nice in adding control, especially to some patients who did not get good control using just one drug. Which leads us finally to what are the problems, especially the implications for our patients who are taking these DMARDs. I mentioned many times they are relatively toxic. GI problems, for instance, are fairly common. Problems with nausea, vomiting, cramping, diarrhea, fairly common in many, many patients. A little more serious pulmonary toxicity is an issue. Problems with oxygenation of the blood and breathing and simply dyspnea. Hematological disorders, we do see problems with anemias, red blood cell formation, as well as some white blood cell problems. Fever, rashes, and many other problems are, again, pretty common with a lot of these drugs. So our major implications are simply to be aware that many different systems are affected by these drugs, which completely makes sense when you consider they are affecting the immune response. So we must be alert for any untoward or just simply inexplicable effects. Patients that are starting to have much more trouble breathing, or are much more tired, possibly due to an anemia, or more subject to infections because of white blood cell problems. Fever and rashes might indicate an allergic or a hypersensitivity response, or really any other thing that goes wrong or it just looks odd in a patient. So that concludes our discussion of arthritic drugs. This is an area of hot research. I sure will see other interventions being introduced to the market in both of these areas for both osteo and rheumatoid arthritis. So very important area where drug therapy and rehab, physical therapy are linked to each other.